right, so today we have Dr. Fernando Caravaggio, is that right? Perfect. Currently, he's a postdoc at UT in the Department of Psychiatry, and he does all of his imaging research at CAMH. He uses multiple modalities, so kind of our bread and butter, what we'd like to be our bread and butter here, so PET and functional MRI and also MRS. And so today he's going to talk to us a little bit about some of the work he's been doing in dopamine, PET imaging, and schizophrenia. So welcome. Thank you for coming.
Thank you very much. First and foremost, I really appreciate everyone coming today. Thank you so much. And I'd like to give a special thank you to Dr. Laurie Tolmanen and Dr. Cynthia Jumon for inviting me. I really, really appreciate it. So today I'd like to talk about a specific radio tracer that we created at CAMH called carbon-11 PHNO. And before I get into it, I want to say a little bit about PET, just in case there's people in the audience who doesn't know how it works. So to make a very complicated story perhaps a little bit too simple, we have different compounds which bind to different targets in the body, and we can incorporate into these compounds radioactive isotopes which undergo radioactive decay. And for example, we have carbon-11, and when it undergoes radioactive decay, a positron collides with an electron, they annihilate each other, and this annihilation event causes 2 photons to be released. And what the scanner does is it picks up where these photons are, and using coincidence algorithms, it can tell us where in the body this molecule is binding. And so I love to show this slide. It's a little piece of history. This was the first attempt to ever measure dopamine receptors in the brain using PET, using radio-labeled chlorpromazine. As we all know, chlorpromazine is an antipsychotic, and it binds primarily to dopamine D2 receptors. And you can see from the picture that it didn't work. It wasn't until 1983 when the first imaging of dopamine receptors was accomplished using the radio tracer NMSP. It wasn't until much later that people realized that there are certain radio tracers that could actually competitively bind at the receptor. And that would be this one here, carbon-11 rapid bind. And what's special about this is that because it's competitively binding, you can do some really interesting measurements. So for example, this is the first paper to measure the occupancy of antipsychotics at D2 receptors in the stratum in people with schizophrenia. Now, why is this important? Well, it was important for clinical practice. So way before all this PET stuff, there was a guy by the name of Dr. Phil Seaman at the University of Toronto, and he proposed that how well antipsychotics are at treating schizophrenia has to do with how well they can block D2 receptors. And so this is just a correlation between the average dose that doctors were giving to patients and how well they could stick to D2 receptors. And using PET, they took this in vitro work and demonstrated it in vivo. So through multiple studies using RapidPi, it's been shown that there's a therapeutic window of efficacy of these antipsychotics for treating people with schizophrenia through blockade of dopamine D2 receptors. So the story goes that if you have less than 60% occupancy of D2 receptors, you're probably not going to get a clinical response to these drugs. And if you have over 80% occupancy of these drugs, you're going to get some unwanted side effects. Some other cool stuff you can do is measure the half-life of a drug at the receptor. So this is a study that we did a long time ago using ziprasidone. And what we did was we gave a single dose of ziprasidone, and we scanned the patients at 3 separate times. And you can see that after 5 hours of injection, there's lots of binding of the drug in the brain, but then over the course of the day, it disappears. And so here we can say for sure that the half-life of this drug is pretty quick compared to the other drugs. Now, what's also interesting is that we know that from PET imaging that D2 receptors decrease with age. They decrease by about 30% across 20 to 70 years old. And so we decided to do a dose reduction study, because maybe these patients with schizophrenia, as they get older, maybe they need less drugs because they have less D2 receptors available for the drugs to work on. And what we basically showed was that you could reduce average doses of antipsychotics in elderly patients with schizophrenia by up to 30% and not have any recurrence of symptoms. And so we can now say something like this, that as people get older, this therapeutic window actually changes. So that's all well and good. It seems like PET has helped us a lot in terms of treating patients with schizophrenia. But what else can it teach us? And what it can teach us is measures of endogenous dopamine within the brain itself. So this picture here is what's called the classical model. So at baseline, rap-LPI is going to bind to some dopamine receptors in the brain, but some of those receptors are going to be also occupied by endogenous dopamine. So if I have a condition where I increase dopamine in the brain, I'm going to displace some of the binding that rap-LPI could have had. So if I measure then the percent change between a baseline scan and a scan where I increase dopamine, I can measure how much dopamine has been released. Conversely, if I have a manipulation where I decrease dopamine levels, there's now more binding sites for rap-LPI, and so the percent change then is how much dopamine was at the receptor at baseline. So how is this commonly done in the field? Well, there's lots of different drugs that, for example, inhibit the dopamine transporter, which would cause dopamine levels to be increased in the synapse. And so this was one of the first papers to look at, to measure dopamine release in response to amphetamine in healthy people using rap-LPI. And kind of what's been shown in patients with schizophrenia is that using this paradigm, there's more dopamine release in response to amphetamine in first episode of patients with schizophrenia compared to healthy controls. What we can also do is inhibit dopamine synthesis altogether, and that's using a drug called alpha-methylparatyrosine, or metyrosine, and it inhibits tyrosine hydroxylase, which is the rate-limiting step of dopamine synthesis. And so CAMH was one of the first places to do a dopamine depletion study with rap-LPI, and you can see that the rap-LPI binding increases after dopamine depletion, and so that could be used as an index of endogenous dopamine at the receptors. Why is this important? Well, in schizophrenia, it seems like they have more endogenous dopamine in the striatum compared to healthy controls, and it's actually correlated with their response to antipsychotics. So the more dopamine you had at baseline in the striatum, the more likely you were to respond to an antipsychotic. And then future studies later showed this was actually more specific to the dorsal striatum rather than the ventral or other parts of the striatum. So far I've talked about rap-LPI, I've talked about other tracers, and all these tracers have been antagonists for the dopamine D2 receptor. Now, why is that important? Well, there was this idea, mostly from in vitro literature, that the dopamine receptor, which is a G-protein coupled receptor, exists in two conformational states. So when the receptor is bound to its G-protein, it's in what's called a high affinity state. It wants dopamine to bind to that receptor. Once dopamine binds to that receptor, the G-protein uncouples, creating this signaling cascade, and it's now in a low affinity state. Dopamine doesn't want to bind there anymore until the G-protein is recycled and recoupled. Now, it seems like this affects agonists, so things that bind like dopamine at the receptor. But this doesn't affect antagonists, like antipsychotics, which bind to the receptor regardless of their G-protein coupling. So the idea was, if we had a radiotracer that was a radio-labeled agonist at the D2 receptor, this might give us a more functional measure of dopamine functioning in the brain. And so this is kind of the theoretical schematic model, if you will. So if we assume, this is from in vitro work, that half of the dopamine receptors are in a low affinity state and half are in a high affinity state, then there's different populations which PHNO and rap-LPI can label. And so just by virtue that PHNO labels fewer sites than rap-LPI, PHNO would be more sensitive to changes in endogenous dopamine than rap-LPI, and could maybe give us a more meaningful physiological measurement rather than rap-LPI. So in 2005, CAMH synthesized PHNO, which then was the first and only agonist for D2 receptors. And we can see that there's a couple of differences between these two tracers. So the first is, if we look in the dorsal striatum, as we would have predicted, there was less binding compared to rap-LPI. So it seemed like rap-LPI labeled way more sites than PHNO, and that's what we wanted. That's what we expected. When we got to the ventral striatum, it was a little bit of a different story. It seemed like there was really high binding in the ventral striatum of PHNO. And there was actually even binding in the midbrain, which you don't see with rap-LPI. And it turned out that these were D3 receptors. So it turns out that for some reasons that we still don't understand, this radiotracer prefers to bind to D3 receptors in vivo over D2 receptors. And so, based on many competition studies, it seems like 100% of the signal in the dorsal striatum with PHNO is binding to D2 receptors. 26% of the signal in the ventral striatum is binding to D3 receptors. 68% of the signal in the globus pallidus is D3 receptors, and 100% of the signal in the midbrain is from D3 receptors. Okay, so that's an interesting property of PHNO. is it more sensitive to changes in endogenous dopamine? So the first group to test this was Shuffle and colleagues in 2012. And they had patients scanned with occupied and PHNO, and they gave them an amphetamine challenge. And they found that PHNO was displaced at a greater extent than occupied in response to amphetamine, specifically in the lobe pallidus, ventral striatum, and the putamen. Now, what about the opposite? What about measuring endogenous dopamine levels with PHNO? So we were the first to do a dopamine depletion study with PHNO in healthy people. And what we did was we had people stay at the hospital overnight. They had 3 visits. And during this time, we gave them multiple doses of metharazine or alpha-methylparathyrazine to inhibit dopamine. And we found a really big increase in binding after dopamine depletion, about 33 to 36%. And this was way more than what had been previously reported in the literature with occupied, which was at that time around 16%. Just in terms of effect size, these are really big effect sizes in the stratum, ranging from 1.64 to 4.8. And if we just compared a meta-analysis of effect sizes with occupied, it's sitting around 1.5. So it seemed to be way more sensitive to changes in endogenous dopamine than occupied. You can do something else which is pretty cool, which is you can correlate the baseline binding of the tracer with the percent change in the tracer after depletion. And so what this is giving you is an index of how much of the variance in baseline binding is being affected by individual differences in endogenous dopamine. And so we can say that around 56% of the variance in PHNO binding at baseline is probably accounted for differences in people's dopamine levels. Another cool thing you can do is, with this data, is you can say, are we actually measuring dopamine? And one way to do that is to estimate the dissociation constant at the receptors using this data set. And so what we find is that just like radiolabeled dopamine, which has a dissociation constant of around 20 nanomolars, we see around 20 nanomolars with PHNO. So it seems like we actually are measuring dopamine levels with this tracer. Okay, that's all very good. What about schizophrenia? And unfortunately, this is the part of the talk where I say we ran out of money because things got expensive. But the idea was something like this. Both dopamine and antipsychotics compete for binding at the receptor at baseline. And so does our radiotracer. So here we have 3 competitors, and if we have a simple story, it looks something like this. But if we have this complicated D2 high, D2 low story, it gets extremely complicated. And so many people in literature, including Dr. Steeman and Dr. Frankel, hypothesized that maybe antipsychotics block less D2 receptors in people than we thought. Because it seems like these antipsychotics prefer to bind to these low sites rather than compete with the agonists at the high affinity sites. And so we wanted to test this in patients with schizophrenia. So the way we did that was we had medicated patients with schizophrenia who were kept on the same dose, same plasma level at both PET scans. And during one of the PET scans, we depleted their dopamine. And so if we focus on the stratum data, we can see that at baseline, patients have less binding because they're on antipsychotic, so there's less availability for the tracer. But then after depletion, the binding actually increased, suggesting that there were dopamine sites that were not accessible by the antipsychotic, but were accessible by the agonist PHNO. And actually, the percent change in this binding was higher compared to healthy controls in the left caudate and the right putamen. And so, if we put it all together, it looks something like this. That the antagonist, the antipsychotic, and occupied compete for more or less the same sites, and you occupy really only 64% of the total receptor sites, leaving a whole bunch of other receptors unengaged by the antipsychotics, but can be engaged by agonists. Now this is important for treatment because it suggests that things like adding a dopamine partial agonist like aripiprazole, polypharmacy, might actually be doing something. It's not the case that we've just blocked everything and now there's no more room for engagement. We actually have now options in terms of polypharmacy, if that's the route we want to go. Now what about an amphetamine challenge in schizophrenia using PHNO? Unfortunately, we haven't done those studies yet, and they're probably not going to be forthcoming for a while. But I did want to point out this one study by Frankel and colleagues, which used a different radiotracer called NPA, which is also an agonist. Now, unlike PHNO, NPA doesn't have higher affinity for D3 receptors in vivo, don't know why, and for some reason it also has much lower binding at baseline than PHNO. And it seems like the amphetamine challenge showed no difference between healthy controls and patients using this tracer. Whether this would also be true for schizophrenia, patients measured with PHNO, it's unclear. But it's something to keep in mind that the agonist radiotracer world is more complicated than I'm presented. So in summary, PHNO may offer us a more sensitive measure of dopamine changes in people with schizophrenia and healthy controls. And future studies should focus on using amphetamine challenges with this tracer in patients with schizophrenia. And hopefully this tracer can also tell us something more about how to best optimize the dosing of antipsychotics in patients with schizophrenia. Now I'd like to go, if I have time, on a quick side tangent, which is that my first love when I was studying neuroscience was the retina. And this is actually a picture of the retina that Ramon Cajal drew that I took at the museum in New York. And as I was analyzing all these PHNO scans over all these years at Cambridge, I noticed something very strange, which is that PHNO showed a lot of uptake into the retina. And this was not shown with Rapid, and it was not shown on the lower resolution cameras that we had at the center. And so, because I had this background in the retina, I just assumed, oh, it's just binding D2 receptors. Because I knew from the animal literature that there was no D3 receptors in the retina. But then I was at SFM in Washington a couple years ago, talking to a friend of mine who's an ophthalmologist, and he says, how do you know there's no D3 receptors in the retina? And I said, you know what, you're right, I don't know there's no D3 receptors in the human retina. And so luckily, across the hall from me was a postdoc who does targeted mass spectrometry, and we sat down and we figured out that there's actually some unique peptides that we could label that belong to the D3 receptor but not the D2 receptor. And so this offered the possibility of measuring D3 receptors and D2 receptors in human tissue. And so what I did was I went to the St. Michael's Hospital Retina Bank, and I collected all the retinas of schizophrenia patients they had, which was 4. And then I got matched out the controls, and the question was, can we actually detect D3 receptors in the retina of these samples, and are they different between patients and controls? And we found that yes, even though it's at very small levels, we could in fact quantify D3 receptors in the human retina, and it seemed like they were decreased in patients with schizophrenia, as well as D2 receptors. Okay, so the question is, what are we measuring with PHNO? Is it D2 receptors, is it D3, is it a mix of both? And the first thing to notice is that the time activity curves in the retina look very strange. So the red line is the cerebellum, which is our reference region for PHNO, and the blue line is the retina, and that's a really weird time activity curve. But nonetheless, it could still be fit to the SRTM, and it wasn't completely terrible in terms of the model fit. And so, doing it in our sample of patients with schizophrenia and healthy controls, we see no difference in PHNO binding between the two groups, either measured with SRTM or the MRTM. Now you're probably thinking this is probably just an artifact of some kind, and so I reached out to the people at Yale who also have PHNO scans to see what their data looked like. Now what's different between their scans and our scans is they scan for an extra, we scan for 90 minutes and they scan for 120 minutes. So their data set's a little bit longer. And what we found was that their time activity curves looked actually a lot better. Their retina time activity curve looked a lot like the locus pallidus time activity curve, which is the D3 preferential region. And so using their data set, they also had arterial samples, and we could see that PHNO binding and measured with arterial samples and with the reference tissue method were correlated with each other. So perhaps this is not just an artifact, maybe this is actually something. There is displacement data using D3 antagonists, but I'm not allowed to show that today. But just know that it exists and it might get published one day. So, long story short, it seems like PHNO may allow us to quantify dopamine receptors in the retina in humans for the first time. what this means for psychiatry is unclear, but it could lead the way for investigating whether certain kinds of antipsychotics actually get into the retina or not, or other kinds of drugs, and see if this is related either to biomarkers of disease or visual deficits. And with that, I'd like to thank everyone at MH that I work with, including Dr. Ariel McGrath, Dr. Gary Erlinson, and everyone at the Center for Atrial Mental Health. Thank you very much for your time.
I want to ask about that retina thing. Do you think we could use that instead of PET scans one day? Which we could measure the 3 receptor levels from the eye rather than from the brain and correlate that with the rest.
So funny thing.
Could you get a measure of the 3 receptors through eyeball somehow, or?
Yeah, see, I don't know. I'm not sure. Because they do their own kind of ocular tomography, which is retinal thickness. So I don't know how that can be combined with the PET, but that's something that probably could be combined in the future. So if like retinal thickness correlates with dopamine receptor availability, then it can be used as a proxy kind of thing. And there was people at Columbia actually who were interested in looking at how people view different luminances, right? And giving them amphetamine, and that changes the way people perceive luminance. And so the idea was, could we correlate dopamine release in the actual retina with the changes in visual perception? And that's something that would be really cool to do in the future as well. Especially in patients with schizophrenia, if we think that they're more susceptible to the effects of amphetamine, it's also true they're more susceptible to the visual effects of amphetamine. And that's just something we don't know.
I have another question. Could you talk about like what are the directions that that people are going and manage right now? What do you think are big things in the next few years?
So the big things in the PHNO world would be looking at how insulin controls dopamine levels in the striatum. So the idea is that there's all these metabolic abnormalities in people with schizophrenia. And this is even before they're on an antipsychotic. And one of the biggest cited papers ever in the history of PET dopamine is Noah Volkow's BMI paper, that people who are severely obese have less dopamine D2 receptor availability. And that's been extended to show that people who are obese or insulin resistant have less dopamine synthesis capacity, they have less dopamine transporters. So there's something happening with obesity. And the question is, how does that help us understand what's happening in neuropsychiatric diseases? And so we're going to be doing a insulin depletion study. So a PHNO scan when people are given saline or another PET scan when they're given an insulin depletion paradigm, and see how that affects dopamine levels in the striatum. The hypothesis being that when you deplete insulin, you have this hyperdopaminergic response. And so actually a hyperinsulinemic state is probably beneficial for people with schizophrenia. And I know people get cringy when I say that because of the history of insulin shock therapy in schizophrenia, but maybe it wasn't just the brain reset, maybe it actually was a dopamine reset. So that's just purely hypothetical speculation. In terms of non-dopamine tracers, we're really focusing on SV2A, and we're really focusing on tau. So the main focus will be treatment-resistant versus treatment-responsive patients to positron, and how they differ in SV2A levels and MRS measures like glutamate.
Thank you, very interesting work. So just like with this early pitch finding in the retina, early on you showed a slide. It was a whole body scan, was it, with your ligand? So I was just wondering, where else do you see the dopamine binding in the body?
In the liver.
Yeah.
There's lots of D2 receptors in the liver.
But there were many spots when you showed your initial slide with binding.
I'm not too sure which ones are promoted as specific, because I think that's just the general scan, but the one that's really specific would be the liver.
I see.
Yeah. Sorry, it's yeah. Well, we don't do full body scans often. It's not at our site, it's at a different site. So that's something that you guys can do really well, which is the full body PHNO scans for sure.
And is it tricky to synthesize? Is it a tricky synthesis, or is it, yeah, it's really fun?
Nobody likes synthesizing trace. And in some people it can cause nausea for reasons unknown. No. There's a whole bunch of chemists everywhere.
Have you thought about branching out to other dopamine, other diseases affected by dopamine, like Parkinson's and that?
So PHNO has been used in patients with Parkinson's. Unfortunately, that's not my lab's area of expertise, but Dr. Strafella at CAMH, she's the expert on PHNO imaging in Parkinson's. He has lots of good papers about it. Mostly increased D3 in the midbrain in Parkinson's.
In the beginning, you were showing that maybe by better understanding the dopamine system in schizophrenia, we could predict those who will respond better to certain type of antipsychotics. So I was just wondering if you could maybe elaborate how you could see that would be used in the future for predicting those who will respond well to a specific type of antipsychotic, or if you think it would be used ever, or it's just cool results.
The biggest issue is the cost of the PET imaging, right? So the idea would be to have other markers which relate to the dopamine markers that could help you get an estimate of the dopamine levels. And I think where that's really being pushed forward is the glutamate stuff. So it seems like having increased dopamine levels in the striatum goes along with having increased glutamate levels in the striatum. And so there's two parallel pieces of work with F-dopa and APT on the one hand measuring dopamine, and the MRS people measuring glutamate, and they both show the same thing. And if they have increased dopamine or glutamate, they're more likely to respond to the antipsychotic. And if they do respond to the antipsychotic, the levels seem to somewhat normalize. And so maybe in the future, we could use MRS as a proxy for these dopamine levels. But I should also mention that this is probably only true for the striatum. It doesn't seem like it's true for the cortex or other regions.
When you say respond to the antipsychotics, are you saying positive symptoms only, or both?
That's basically the wrong thing. That's a tricky issue because you will get some negative symptom improvement, but the big story is that negative symptoms at a certain level won't get any more improvement, so they really don't improve with antipsychotic treatment. So when I say improve, I'm not being specific. It is positive.
Is it positive? Okay. So this is kind of a big question, I guess. How do you think dopamine fits into the story of negative symptoms?
It's a good question, because dopamine abnormality in schizophrenia seems to be restricted to the dorsal striatum, right? And we don't usually think of negative symptoms being related to dopamine in the dorsal striatum. Now, the Krigelis paper, let me pull it up quickly, I can get to it. Anyways, he showed that, and it's the only paper to show this actually, that so he measured negative symptoms and found that negative symptoms were correlated with dopamine levels in the ventral striatum, but not the other parts. So dopamine in the ventral striatum probably has a role with negative symptoms, and this is something we know in rodents, right? That blocking D2 receptors in the ventral striatum causes apathy and motivational deficits. But actually showing that in humans and showing it in patients with schizophrenia had not been forthcoming. So it could just be that antipsychotics are not adding more negative symptoms to the patients. So whatever dopamine deficit that's there, which we can't see, which doesn't seem to be different from healthy controls, it's as low as it's going to get. Like their negative symptoms are there. If that makes sense.
So they're kind of separate then.
Isn't it negatively correlated? So like people with lower dopamine release in the BSD have more negative symptoms?
Yeah. So
it's the opposite relationship to positive symptoms.
Yeah. But they're not different from healthy controls.
Yeah, but they always, their group would say that it's probably a power issue. Like if you had enough people, you'd see a higher signal independence in patients.
And the other issue too is not everyone has the scan resolution to measure the ventral striatum.
Yeah.
So a lot of the seminal papers never even have the ability to measure the ventral striatum.
Mm-hmm.
So it could be a scanner issue, it could be a power issue.
Mm-hmm.
But But as of right now, we can't say.
They weren't so confident in that finding too. They said the only reason they reported this is a reviewer told me to.
Yeah. I've had a couple of reviewers tell me to report it too.
But the other story of dopamine too is like what's going on in the cortex in schizophrenia. And there's this low dopamine in the cortex might be related to cognitive symptoms, negative symptoms. And they did that study with FLB, the same group that I was involved with. And the main punchline was there was a relationship to negative symptoms or cortical or cognitive symptoms, but in some of the sub-analyses there were signs of relationship that lowered dopamine release in the cortex related to some cognitive factors. And also I found it was related to actually social economic status.
So that's actually our biggest predictor of D2 receptor availability.
Okay.
Is socioeconomic status.
Mm-hmm.
That's
right.
Yeah. That's been replicated, I think, 3 times now.
Mm-hmm.
So, and there's that really famous study, I forgot the guy's name, but he did it in monkeys where monkeys have a hierarchy.
Mm-hmm.
If the alpha monkey has high D2 receptor availability, he doesn't like cocaine very much because he has lots of friends.
Right.
Take the alpha monkey, put him in a house where now he's the beta, his D2 receptor levels decrease, and now he really likes cocaine. So there's this, to me that's probably one of the most interesting avenues of D2 research, is this social hierarchy, social status, but not so many people are doing it in humans.
How do you measure social status?
In people?
Yeah. What specific measure do you use?
There's a bunch of different socioeconomic status scales. It's just self-report.
Okay.
I don't go to your house and see if you're a beta or alpha. But you probably should. And if I didn't, I'm not an expert on social cognition, but it's probably a very simplistic view to look at human behavior. Our social hierarchies are way more complex.
You do all things, right? Not just your social status, but everything that comes with it.
Mm-hmm. Yeah, it's just a correlation, it's not causation.
You should try scanning the Trump a little bit.
We should do a narcissism study.
You're a monkey with symbols.
See, I promised I wouldn't be political.
How often did you find people were getting nausea from PHNO?
So probably about a third of people.
Yeah, that's the problem.
And did it mean they had a hard time getting through the scan, or?
Sometimes they throw up.
Okay.
Sometimes it just be like, oh, I need to just get my bearings for a moment and then get them back in the standard kind of thing.
Okay.
Try to inject it really slowly.
It doesn't do anything. Yeah, we still don't really know why. There's some people who are really susceptible to injection of PHNO. We think it has to do with the reticular activating system, which is like your flow-up response and has these receptors, so maybe it's activating those. But nobody really knows. But every time I have a bad night after a bar, I think about the straight for sure.
If you have 5 minutes after the talk, I'd probably pull up that data from the secret data set. See PHNO plus amphetamine in 50 people.
Oh yeah, that'd be awesome.
Yeah, after you guys talk about it, I think I can find it for you.
Yeah, I'm actually really surprised that no one's actually published it yet. Because that was really the whole goal of creating PHNO.
Yeah. Well, I think they're still planning to do it. I think they're working on a big grant to